Hello and welcome to Sleep Review's webinar for people with narcolepsy, shortening the diagnostic turnaround time. I am Sri Roy, editor of Sleep Review and your host. I'm here with three excellent speakers, Julie Steiner, Alyssa Cairns, and Timoteo Oleg-Baile. After the three presentations, we will answer as many questions as we can live. So throughout today's webinar, submit your narcolepsy-related questions via the Q&A box on your screen. Also, the complete slide deck is available for PDF download. Refer to the box on the right-hand side of your screen that says Slide Download and Links, and click on the first link anytime during the webinar. For those interested in the AAST credit, please note that the CEC is for the live version of the webinar only. It is being recorded, but the pre-recorded version isn't eligible. On the webinar registration page, you must also have said yes in response to the question about wanting the credit. For privacy reasons, we will not be submitting the full roster of attendees to the AAST, only those who requested the credit. So today, you must watch all three presentations and complete the exit survey that is on the left-hand side of your screen. Even if you don't want the credit, we would appreciate it if you take the survey. Once you take the survey, the form will simply close. You won't get an immediate confirmation. But if you don't get the certificate needed for the AAST by March 17th, then email me at sroy@allied360.com so we sort it out before I submit the final roster. Let's start today's webinar with an audience poll. Please select from the choices on your screen. In the past 6 months, have you initiated a conversation about narcolepsy with any patient who came through your door? Your answers are either yes or no. Make sure to click the Submit button so that we include your response in the calculations. Select yes if you broach the subject of narcolepsy with one or more patients, and no if you have not brought up the disorder to a single patient recently. I'll give you just another second to vote, and then we will look at the results. Okay, about 44% say yes, they have initiated a conversation with narcolepsy with the patient in the past 6 months, and the majority say no, about 55% have not. That gives us a good feel for today's audience, and I expect we'll get advice on how to initiate that conversation, including relevant questions to ask the patient that you may not have previously thought of. Thank you, viewers, for your participation. Now it's my pleasure to introduce Julie Steiner, MPH, CHES. Ms. Steiner is a sleep health advocate and clinical assistant professor at the University of North Carolina Gilling School of Global Public Health. She currently serves on the advisory board for the National Institutes of Health Center on Sleep Disorders Research. After suffering with sleepiness and cataplexy for more than 25 years, she was finally diagnosed with narcolepsy at age 35. Before she was diagnosed, Steiner felt tired all the time and experienced vivid dreams and hallucinations. She saw a number of doctors who misdiagnosed her with everything from ADHD to vitamin deficiency until finally one physician suggested she go in for a sleep test. Julie Steiner is passionate about raising awareness about narcolepsy. She encourages others to explore their symptoms and break through the cultural stereotypes of the disorder. Welcome, Ms. Steiner. We're ready to hear your insights.
Thank you, Sri. I'm happy to be here. What I'll be sharing with you all today is really the patient perspective on delays in narcolepsy diagnosis. And this is based on my own experience as a person with narcolepsy who took 26 years to receive an accurate diagnosis. And also from what I've learned in getting to know others with narcolepsy who also had these long delays in diagnosis. So I'd like to start by giving you just a brief overview of my own story. When I was 9 years old, I just stopped waking up in the morning. Prior to this, I'd been a really energetic child. I loved going to school every day. But around the 4th grade, I developed this overwhelming and all-consuming sleepiness. It was almost agonizing. and I just couldn't wake up in the morning. My mom had to start dressing me for school while I slept. I was just really lifeless and limp, almost like a rag doll. I remember how difficult it was for her to get my shoes and socks on in the morning. It was just a real struggle. I could really not go more than 2 hours without feeling this overwhelming urge to take a nap. And over time, I developed all 5 symptoms of narcolepsy. So not everyone with narcolepsy has all 5 symptoms, but I did over time develop these. Within a few months of my initial symptoms, I started having lifelike and frightening dreams. And often I would feel like I was being attacked or there was a presence in the room. I might have a sense that I couldn't breathe. And eventually these started occurring alongside something called sleep paralysis, where I just couldn't move as I was falling asleep or waking up in the morning. I was awake, but I had the sense of I couldn't move. I felt like I couldn't breathe. I couldn't call out for help. I had trouble sleeping through the night. I started to experience a very severe brain fog. I found it hard to concentrate, to participate in class. I became clumsy and uncoordinated. I was dropping things a lot. My knees would kind of give way without warning. I also experienced really severe brain fog. I found it hard to concentrate. And I gained weight right around the time that I developed the sleepiness. I gained a fair amount of weight, which was unexplained, which I've later learned is common with narcolepsy onset. And I also experienced some difficulty socially because I was really just too tired to keep up, and I found myself feeling overly emotional a lot of the time. So it was clear to my parents, I think, that something was wrong, and my mom started taking me to pediatricians, but I had a lot of exams and tests, but we were reassured over and over again that I was a healthy child, and so over time, I think my sleepiness became, to others, seen as more of a behavioral issue or a lack of motivation, so I really tried to hide my sleepiness. I didn't talk much about my symptoms. And throughout the years, I managed to get along fairly well, but everything was really a struggle. And I did receive a lot of criticism from the people around me for being lazy or unmotivated or not quite living up to my potential. So along the way, I was diagnosed with things like ADHD, depression, vitamin deficiency, even just burnout. I was tested for just about everything you can imagine, thyroid problems, autoimmune disorders. I was prescribed all sorts of unnecessary medications, many of which probably made it actually harder to diagnose my narcolepsy. And I saw over 40 healthcare providers throughout 26 years. So I finally saw a primary care provider in my 30s, and she sort of set me on the path of referring me for a sleep study. And eventually I was diagnosed with narcolepsy at age 35, more than 26 years after my symptoms first started. So as we go through some of the reasons for the diagnostic delays in narcolepsy, I'll be sharing a little bit about my own experiences at various points throughout that 26-year journey in getting to a narcolepsy diagnosis. So before we get into the reasons for delayed diagnosis, I'd like to talk a little bit about the impact that living with undiagnosed and untreated narcolepsy can have on a person's life, because I think this really underscores why a quick diagnosis is so important. The disease burden of narcolepsy is high, even when it's treated. And it can be even greater when it goes undiagnosed because you experience problems with memory and concentration, fatigue, trouble processing information. You might have poor functioning at school or work, experience a lack of energy or motivation. And there are a lot of lost opportunities due to a lack of treatment. Longer diagnosis is also associated with weight gain or a higher BMI. So I mentioned that I gained weight at the onset of my symptoms. So the longer this goes on, the more chance you have of gaining weight and that becoming a problem. In addition, people who don't realize that they have a real medical condition often face a lot of unjustified criticism from friends, family, and employers for being lazy or not living up to their potential, and they may find it difficult to fully live up to their own expectations. So over time, especially if narcolepsy develops in childhood, this can really wear away at a person's self-esteem and result in a negative self-image. People with narcolepsy often see multiple healthcare providers over the years, and they have dozens of tests and treatments, just like I did. So there's also this issue of high healthcare resource utilization in people with narcolepsy. And misdiagnosis often leads to inappropriate treatment that can mask the symptoms, which could further delay the recognition and diagnosis of narcolepsy. So overall, there are many negative health, social, and economic consequences associated with diagnostic delays. And the longer this goes on, the harder it is to recover and repair once you do have a diagnosis. So living with this undiagnosed narcolepsy for so many years, it can really shape the person that you become. So I think, getting to a quicker diagnosis, it's really the opportunity to give a person with narcolepsy a chance of living a really full and productive life. So the good news is that research is showing a trend in shorter diagnostic delays for narcolepsy, which is great. But it's still estimated that up to half of all affected patients may actually never learn that they are suffering from narcolepsy. So, patients just like me who are out there suffering and they don't have any idea why. And because the disease burden is so high, as I've just mentioned, even a short delay could result in negative consequences. So I'm going to start with just a few general reasons that delays might occur and then move into some more specifics. Overall, I think the biggest problem is a lack of awareness of narcolepsy and its symptoms. I think this is the major reason for diagnostic delays, and I'll talk more about that in a minute. The absence of cataplexy often results in a longer delay for diagnosis. So if a patient's not experiencing clear-cut cataplexy, which providers are sometimes more familiar with this as a symptom than the other symptoms of narcolepsy, then they might not consider narcolepsy. And in my case, my cataplexy was very mild, so I think that contributed to a longer delay for me. Onset before age 18 is a predictor of delayed diagnosis. So narcolepsy and cataplexy may look different in children than adults, and this makes it even harder to recognize. So in children, cataplexy might appear as this low muscle tone where the child is floppy, kind of like a rag doll, sort of like I was. And there's a more prominent facial involvement and some movement abnormalities. So it can make cataplexy harder to recognize in children. This typically subsides over time and presents as sort of the more typical picture of cataplexy. But in children, sleepiness can look like a lot of different things. It can look more like a behavioral issue, hyperactivity, aggression. Children with narcolepsy often experience weight gain or obesity, as well as early puberty. And children just aren't able to articulate their experience quite as well as adults. So you might not realize that what they're experiencing is this overwhelming sleepiness or cataplexy. I think also the presence of comorbid conditions like depression, anxiety, other sleep disorders. There's also confusion with other conditions that have excessive daytime sleepiness as a prominent symptom, so that can contribute to delayed diagnosis. There is some research suggesting that being female or having a higher BMI has also been associated with longer delays, which is kind of interesting because weight gain for many patients does occur with the onset of narcolepsy. And then finally, the tests that we currently have for narcolepsy, they're not necessarily the most reliable, and there isn't an easy, accurate diagnostic test that can be used in a clinic setting. So I don't think that we can really talk about delays in narcolepsy diagnosis without addressing the cultural stereotypes and stigma around narcolepsy and also sleep in general. there is such a stigma around sleepiness in our society, and that it's a sign of weakness or laziness, or somehow it's a character flaw. So I think people with narcolepsy who are experiencing this overwhelming sleepiness, they often try to hide their sleepiness because they feel guilty or ashamed, like they're doing something wrong. And that certainly was the case with me. And then you have these pop culture depictions of narcolepsy that are just so inaccurate. And they suggest that sleepiness associated with narcolepsy is harmless and even humorous in some ways. So when I first learned that I might have narcolepsy, I immediately thought, no way. I don't just fall asleep in the middle of a conversation or while I'm walking down the street. I'd seen a handful of movies and comedy skits where characters with narcolepsy were engaged in some kind of a stimulating or high energy activity like playing sports or in the middle of a really animated conversation, and they just fell to the ground asleep. And it's always portrayed in this really comical way. And I really thought that this is what narcolepsy was. So if I'd seen a portrayal of narcolepsy where all 5 of the major symptoms were accurately presented, I would have known immediately what I had, but that's just not what you see. And I've worked in medicine and public health for most of my career, and I consider myself to be a pretty savvy healthcare consumer. And I did have some sense that I had a sleep problem, and so I'd be on these websites looking at various sleep disorders, but I never even clicked on the narcolepsy links because I felt so sure that I couldn't have it. But narcolepsy is really invisible in so many ways, and so much of what I experienced with the sleepiness and the hallucinations and the paralysis was really internal. And the sleepiness in narcolepsy can come on very gradually. So I think, people don't talk about all of the real symptoms of narcolepsy. And then finally, I think even healthcare providers are informed by these stereotypes. I've worked with primary care physicians for many years, and it was always so surprising to me how many of them also thought narcolepsy was more like what you see in the movies, when in reality it's quite different and much more complex. So I know that most of you participating in this webinar are sleep specialists, and I will definitely be addressing the possible reasons for diagnosis delay that might happen in the sleep clinic setting. But I think it's really important to take a step back and look at the patient's journey prior to arriving at the sleep specialist, because understanding where a patient has been and what they've gone through to get to you, this can provide you with important clues that might point you in the direction of a narcolepsy diagnosis. Because one thing that I've discovered in getting to know so many people with narcolepsy is that for those of us who have these lengthy delays in diagnosis, we all have very similar stories. And delays can occur at various points along the way for a variety of reasons. So prior to seeing a healthcare provider, once you see your primary care provider, and then once you get to the sleep specialist, you might even have delays there. So I hope that some of this information might help you educate your colleagues as well as referring providers. So before seeing a healthcare provider, what might cause a patient to delay seeing their healthcare provider? So the delays in narcolepsy diagnosis do often begin with the patients themselves because they don't think to seek help right away. It can take up to 3 years or more for a person with narcolepsy to see a healthcare provider. For some people, narcolepsy can come on very abruptly, and the symptoms can be severe, especially if there's cataplexy. And in this case, especially for an adult who has been previously healthy and high functioning, it can be very evident that something is wrong. But for others, the symptoms may come on gradually over several years, usually starting with sleepiness by itself. And when these symptoms don't occur all together, it can be hard to recognize that they are related. So in my case, I didn't even recognize my symptoms as symptoms of a medical condition. I just thought that this is how everyone must feel, and they just had more motivation than I did. And I think a lot of people have this idea that sleepiness is normal and it's just something that you have to push through. It becomes even more complicated when narcolepsy develops in childhood and the symptoms progress into adulthood. So over time, you just kind of come to see this as your normal way of functioning. You don't really know that something's wrong. And sleepiness doesn't always look like sleepiness, and people can articulate it in different ways. So you're unlikely to have a patient come in using the term excessive daytime sleepiness to describe what they're feeling. They might say they're sleepy, but they're more likely to report being tired, fatigued, and they might also talk about cognitive issues, memory problems, trouble concentrating, feeling overly emotional. And again, in children, sleepiness can look very different. It can look like hyperactivity or behavioral problems. And I think given the stigma around sleepiness, people might be too embarrassed to discuss their symptoms with their doctor. And then families might disregard symptoms, making a person with narcolepsy less likely to complain. So I'd been to many pediatricians as a child who reassured us that I was healthy. So my sleepiness became a source of frustration and conflict with the people in my life, and I would literally have to sneak around to find a place to nap. And so I just stopped talking about my sleepiness at all. So before I talk about the delays that happen at the healthcare provider level, I want to just point out the results of the Awaken survey. So this is a survey that was published in 2014, and it looked at awareness of narcolepsy among sleep specialists and primary care providers, as well as the general population. So as you can see here, there are substantial gaps that exist in understanding narcolepsy and its symptoms, even among sleep specialists. So if you look at this chart, this table, you can see that awareness of all 5 symptoms of narcolepsy is quite low, especially among primary care providers who usually only get a few hours of sleep medicine training. And even among sleep specialists surveyed, you can see that awareness of all 5 symptoms is low, as is comfort in diagnosing narcolepsy. So a higher percentage in both groups are able to identify the 2 most prominent symptoms, which are the excessive daytime sleepiness and cataplexy. So you could see where a patient without cataplexy may have a more difficult time getting diagnosed. So what types of delays might occur at the primary care provider level? Well, as we've just seen with the Awaken survey, awareness among primary care providers is quite low. Historically, the time devoted to sleep medicine within medical school curricula has been limited. It's usually just a few hours, if there's any dedicated time at all. So PCPs often lack the most basic knowledge of narcolepsy and other less common sleep disorders. Often if they do suspect a sleep problem, they're more likely thinking of sleep apnea, even in the absence of risk factors. And this is certainly the case for me. I had many suggestions of sleep apnea, even though I didn't have any risk factors and sort of no reports of snoring. I think also sleepiness is ubiquitous in our society, and people are suffering from sleep deprivation for a variety of reasons, including poor habits and lifestyle choices. So I think PCPs hear this complaint a lot, and they tend not to take sleepiness seriously. In my case, they would talk about sleep hygiene a lot and prescribe short-term sleep aids, but it rarely went beyond that. I even had doctors telling me how sleepy they were and how they had sort of learned to go without sleep in medical school. And a person with narcolepsy is more likely to be diagnosed with depression or another mental health issue. And then a cycle of treatment started that probably doesn't improve symptoms. And sometimes these treatments can actually exacerbate sleepiness or mask the symptoms of narcolepsy. So if the PCP doesn't suspect a sleep problem and or if they do suspect a sleep problem and refer a patient for a sleep study, they'll generally order the overnight study, but having not a lot of awareness of narcolepsy, they might skip the MSLT because narcolepsy is just not on their radar. So if the patient doesn't have any concurrent sleep disorders, that sleep study might come back with a negative result, confirming the provider's suspicion that nothing is wrong. And sadly, this is as far as it goes for many patients. So I think that education among PCPs, who are often the first stop, and the ones that are making referrals to sleep specialists, is critical in shortening diagnostic delays. So what are some of the reasons for delay when a patient with narcolepsy does reach a sleep specialist? Again, in my own experience, I think that sleep apnea is the first thing that people often think of. When I first saw a sleep specialist, she did an exam. She looked down my throat. She said, "You have a very narrow airway. I feel confident that you have sleep apnea." I think also if the patient doesn't have clear-cut cataplexy, narcolepsy is often ruled out, and it can occur with other disorders like sleep apnea. So a patient might be tested for sleep apnea. If they test positive, they're treated for that, but their narcolepsy may go untreated. For me, I was initially diagnosed with narcolepsy without cataplexy, but once I started treatment, some of the symptoms that I thought were just due to being clumsy or tired improved. And then as I got to know more about cataplexy and talked with other patients, I realized that in fact I had been experiencing very mild cataplexy for many years that I had just chalked up to clumsiness or being really tired. So I talked with my physician about that, and my diagnosis was adjusted. And when it comes to narcolepsy, like with many other diseases, I think the human body doesn't always follow the classic textbook definition of symptoms. So through getting to know so many people with narcolepsy, I've discovered just how much symptoms can vary from person to person. So some people, like myself, will have all 5 symptoms. Some might have only 1 or 2. Often excessive daytime sleepiness is the only symptom, and others like me may have very mild cataplexy, making and some have much more severe episodes. So no 2 cases are alike, and I think that's very important to remember. And I know I'm getting close to the end of my time, so just a couple more things I want to mention. The ICSD-3 makes the diagnosis of narcolepsy difficult. It's too stringent, and there is too much reliance on the MSLT, which is imperfect. When it is ordered, it's not always accurate. There can be false negatives for many reasons, including medications a patient might be on, patient anxiety, difficulty sleeping in an unfamiliar setting, and this is an experience I had as well. So if all the criteria aren't met, providers don't make the diagnosis. And then briefly I'll mention home sleep testing. I just think it's really, narcolepsy can be missed with a home sleep test, so I think it's really important to carefully screen patients for home sleep testing. And finally, just some of the recommendations I would make. There are many reasons for diagnostic delays, and the main symptom is the lack of main reason is the lack of symptom recognition. So ask the right questions and really listen to what the patient is saying. I had so many experiences where I felt like the healthcare provider I was talking to just wasn't listening to me. They already had their mind made up about one diagnosis or another. Even if a patient has a negative MSLT, really listen to their story. I think you'll discover familiar patterns among patients who have delayed diagnosis. And remember that no 2 narcolepsy patients are exactly alike. The symptoms can present differently, and patients will articulate and describe these symptoms differently. And most importantly, find ways to educate your colleagues and referring providers, whether it's through an organized outreach initiative or even just informal conversations. And finally, just ask the right questions, and these are all on the slide, which I think you all have. And I know provider visits are short and there's a lot to accomplish, but I think just asking a couple of the right questions, take 1 or 2 minutes to ask a few key questions and probe a little bit, can really make all the difference. And just remember that you can learn so much by listening to a patient's story and learning more about their journey. Thank you.
Thank you so much, Ms. Steiner, for that excellent and personal presentation. And you also included a references slide. So for those of you who want to look at those more closely, simply download the slide deck PDF and you can get a printout of the list of references from her presentation. So thank you. Now I am happy to introduce Alyssa Cairns, PhD. Dr. Cairns received her doctorate in psychology from the University of Southern Mississippi and completed a postdoctoral research fellowship at Brown Medical School. She is currently working as a research scientist at SleepMed Inc., where she is exploring the biophysiological phenotypes of central hypersomnia through advanced signal processing of clinical polysomnographic data. Welcome, Dr. Cairns. We're ready to hear your experience.
Thank you, Sheree. Thank you very much. And thanks for having me today. I'm happy to be here and share a little bit about what's going on right now in the sort of cutting-edge research side of exactly what Julie just really set up beautifully, which is that there is this diagnostic delay, and the current tests that we have to assess for narcolepsy are definitely less than perfect. It's kind of the best we have right now with regards to a fairly easy way to tell if the person has narcolepsy, with the exception of, doing a spinal tap, if you will. But, these tests that we have are imperfect. And so what I'm going to do is kind of, I'm going to probe the audience to sort of shift the paradigm a little bit from the current test that we have, which is the MSLT, if the practitioner has the acumen to do an MSLT, versus the actual, nighttime polysomnogram. Okay, so that's kind of setting the stage for what I'm going to be talking about. So essentially, before I get started, let me go ahead and just kind of recap the normal regulation of sleep. Because I think this kind of helps conceptualize or set the stage for things that don't happen as per standard in patients with a central hypersomnia condition. So we call this the dual regulation of sleep. It's the essential sort of interaction between, we call it homeostatic sleep drive, which is on the top. You see those bright blue arrows that are pushing down. Okay, so as we go through the day, essentially we have this accumulation of homeostatic sleep drive. So essentially it's a mathematical equation of the longer that you're awake, the more likely you are to fall asleep, right? So the more likely you're awake, or the longer you're awake, the sleepier you are, and the easier it is to fall asleep. Now, fortunately, we have this kind of a competing drive that is called the circadian drive, or the circadian rhythm, and that is an oppositional force, that is the arrows coming up from the bottom. And essentially what they do is they interact, the homeostatic drive and the circadian drive, they interact throughout the day during wakefulness, and it gives us this sort of consistent level of wakefulness throughout the day, and that's that wake propensity line, that bright green line. So you can see how it's fairly constant throughout the day due to the interaction of the two processes, one that's pushing down, one that's pushing up. That is until the sun goes down, right? When the sun goes down, us as mammals, we are pre-programmed to secrete this hormone called melatonin. And melatonin is the sleepy hormone, and it allows us to initiate sleep and to maintain sleep. And so you can see that that green line is no longer fairly consistent. It dips down very precipitously. Okay, so that's sleep, and it allows sleep to happen and happen well. So research right now is really focusing on what is happening with these the interaction of these two systems that allows patients with narcolepsy to not have that consistent level of wakefulness throughout the day and a consistent level of sleepiness throughout the night. Because narcolepsy, like Julie said, it's unlike what you would see in the magazines and on TV, where patients with narcolepsy, 1 minute they're awake and the next minute they're on the floor, right? What we know about narcolepsy is that it's really this inability for people to have a consistent state, whether it be wakefulness or sleep. So patients with narcolepsy often report a very difficult time staying asleep. Okay, so it's really this dysregulation of the ability to not only stay awake, which is this kind of classic heuristic vision that we have in our minds of what someone with narcolepsy has, but it's also the inability for them to actually stay asleep. Okay, so it's like they kind of can't get relief either way. Now, how do we assess currently for this phenomenon? Well, the current gold standard is the MSLT. And I know that many of you are technologists, and I'm sure that many of you have run MSLTs. You know, it is what we call the gold standard, but it might be more of a bronze standard because we know it's imperfect. It is imperfect. It's the best we have right now, but it's imperfect. And why do I say that it's imperfect? I say it's imperfect because I'm sure many of you as technologists that have run these MSLTs can attest to the many variables that can happen during the MSLT that can really influence the outcomes that have nothing to do with the person's ability to, you know, stay asleep or go to sleep quickly or go into REM. Those include things like environmental stimuli and novelty, discomfort, environmental discomfort, like, you know, if it's cold, if it's too hot, if there's noise. There's so many things, right? And so what we know is that you take the classic type 1 narcoleptic patient. Type 1 is essentially the new way that we classify narcolepsy, type 1 and type 2. Type 1 is what we used to call narcolepsy with cataplexy, right? So it's what Julie's experienced, but it is essentially patients that have this irresistible urge to fall asleep, but they also have this motor phenomenon called cataplexy, which is where they have whether it be a lack of tone and muscle, or they have these actual frank cataplectic attacks where they fall down and, you know, lose muscle tone for X amount of seconds, minutes. That's the kind of classic narcoleptic phenotype, right? There's also type 2, which is essentially narcolepsy without cataplexy, and we'll talk about that a little bit in a minute. But this sort of classic type 1 narcoleptic phenotype, which is narcolepsy with cataplexy for the most part, about 15% of them have negative MSLTs. Okay, so what does that mean? That means that even those that have an actual brain condition where their brains are not secreting this peptide called hypocretin-orexin, and that's what we really think is causing type 1 narcolepsy, is this deficiency in this particular hormone, peptide rather, that's secreted from the hypothalamus. And you take these people and you test them on the MSLT, you would expect that all of them are going to have positive MSLTs. Well, 15% actually have normal MSLTs. So right there, that kind of sets the stage for, you know, okay, something is amiss here. Now, on top of that, we also kind of classically thought that patients with that this short onset REM occurrence during an MSLT was also very specific to this disease, the central nervous system hypersomnia condition called narcolepsy. In other words, it's very rare for someone without narcolepsy to have a short onset REM. And now we know that that's actually not true. We know that not only is there this kind of false negative prevalence that happens with patients with this classic narcolepsy phenotype, but there's also the false positive aspect of it, where there are even healthy people out there that exhibit the phenotype, this experience of a multiple short onset REM phenomenon during an MSLT. So patients who don't have any sleep condition, they don't have sleep apnea, they don't have behaviorally induced short sleep, they don't have circadian misalignment, things that would explain this abnormal, quote-unquote, finding. We actually know that about 3 to 4% of patients that are healthy exhibit this phenotype, okay? And we're trying to disentangle that a little bit and understand, why does this happen? It doesn't happen all the time, doesn't happen frequently, but why does it happen at all in healthy controls? We also know that the prevalence of this abnormal, right, in quotes, thing happens in patients with sleep apnea. About 5% of patients with sleep apnea have multiple short onset REMs, even if they don't have narcolepsy. We also know that especially those that are at circadian misalignment, right, going back to that figure that we talked about with the interaction of the circadian rhythm and the homeostatic rhythm, if you take that circadian rhythm and you misalign it with your sleep-wake schedule, you're going to have REM basically all over the place, right? So we know that patients that work shift work are at a very high risk for having this particular short onset REM on an MSLT, even if they don't have narcolepsy. So we know that they're about 6 times more likely to have multiple short onset REMs during an MSLT than a normal healthy control patient. Okay, that's pretty high, 6 times. Some other things to be considerate of for the MSLT are people that have behaviorally induced short sleep. Okay, so those that have short sleep are about 30% more likely to have multiple short onset REMs. And there's other things to be considerate of as well as like developmental considerations. So like the children who go through like the pubertal period. So when you're going through puberty, there's something that's very different that happens to the circadian rhythm. And there is some evidence to prove that even healthy, normal children going through the pubertal transition actually have multiple short onset REMs, especially in that first nap. Okay, and that has to do with the delay, the natural delay in the circadian rhythm. Okay, the last thing I wanted to bring up is just patients that have depression. There is some data out there that patients with just primary depression actually have abnormalities in REM functioning, and so they actually have more REM or more fragmented REM, and they're more likely to have REM on an MSLT. Now, it's complicated by the fact that depression and narcolepsy kind of go hand in hand, but we do know that there are the upshot of this slide is essentially kind of setting the standard that the MSLT is imperfect because we've got false negatives and we've got false positives. Okay, so I want to really just kind of put that out there for you. So what we're doing now is we're focusing more on the nocturnal polysomnogram. And this is, again, what Julie was referring to in the delay in diagnosis. And this kind of, ties into the last slide, which is we know the MSLT is imperfect. It's more like a bronze standard, right, not the gold standard. And what we're finding is that practitioners, when they rely on it, you're seeing a general delay in diagnosis of about 10 years, roughly. So you can see the first red arrow there is when symptoms, sleepiness, cataplexy, whatever the case may be, happening is between 15 and 19 years of age. Well, a good 10 years later is really when people are ending up, on average, getting diagnosed. Okay, so that's really a whopping number. All right, so there are concerns with the MSLT, and we as researchers are really kind of honing in on other ways to find better ways, novel ways to identify patients with narcolepsy, especially narcolepsy without cataplexy. Because like Julie said, when you have frank, overt cataplexy, it's kind of this thing in the front of the face of a doctor that you can't really deny. But when you don't have frank, very sort of obvious cataplexy, which happens in many, many patients with narcolepsy, it's harder to distinguish this sort of definitional narcolepsy person from somebody who just may have some lack of energy or fatigue or maybe comorbid sleep apnea or depression. There's lots of things that a practitioner may first go down the route to see if they have it and then treat it before they would even think narcolepsy. Okay? So the upshot here is that narcolepsy type 1, which is that classic cataplectic phenotype, is quite different when it presents itself to a practitioner than someone with narcolepsy type 2, where you don't have that frank, overt cataplexy. In fact, narcolepsy type 2 shares more variance with this idiopathic hypersomnia phenotype than really anything. And what is idiopathic hypersomnia? Idiopathic hypersomnia is a hypersomnia condition, meaning the brain is sleepy, just like a patient with narcolepsy. But essentially a couple things happen. Either one, well, they don't have cataplexy, right? Because if they did, they'd be narcolepsy type 1. But they don't meet the criteria for being diagnosed with narcolepsy as per the MSLT. And so this is really kind of the crux of the issue. So if I give a patient an MSLT and they have 2 REM onsets during the MSLT as well as a mean sleep latency of 8 minutes or less, that is narcolepsy, right, as per the ICSD. But what if they only have 1 REM, right? What if they only have 1 and their mean sleep latency is less than 8 minutes? Well, the default diagnosis would be idiopathic hypersomnia. And so, what is the meaning of that 1 additional REM episode, right? Does the Is that really what differentiates these two conditions from each other? Currently, as per the ICSD, it is. And as Julie said, that's a problem because, the test-retest reliability of the MSLT is not strong, right? And actually, recent data by a colleague of mine, Dr. Trotty at Emory, actually provided evidence that about 50% of patients, when tested with the MSLT back-to-back, will swap diagnostic criteria, right? So in other words, they're diagnosed with narcolepsy type 2 at point A. I retest them again a couple years later using the MSLT, and guess what? They're either normal or they have idiopathic hypersomnia about 50% of the time. So what does that mean? Does that mean that they really have idiopathic hypersomnia? Or does that mean that they're normal? Or does it mean that they have narcolepsy type 2, right? So it's hard to distinguish sometimes what's going on here. And relying specifically on one test to differentiate that is incredibly problematic. So like I said before, researchers are trying to find better ways to differentiate these diagnostic classifications. And so we're turning to the Nocturnal PSG, which is really important for you guys, the sleep techs out there, because you're the ones who are going to be seeing this every single night. And I'm going to be asking you to think about, some action steps when you encounter a patient with this unique fingerprint. Okay, so here we are. This is a graph it's a hypnogram essentially of a control patient on the top portion of the figure. You can see that we have REM at about 90 to 120 minutes. After the onset of sleep, and then we have fairly regular periods thereafter, and they become more and more long as the night progresses, and that's due to the circadian rhythm because REM is more predominant toward the nadir of the core body temperature cycle. So that's that kind of typical normal, and I know all of you know that, fingerprint of somebody that has a healthy REM cycle, right? Well, with someone with narcolepsy, you've got much more fragmented REM. And this goes back to that very first figure that we talked about, which is not only do patients with narcolepsy have a very hard time staying asleep, they also have a very hard time staying awake, but they also have a very hard time staying asleep. So here we are, the person with untreated narcolepsy has many more periods of REM. They might be 1 epoch long, they might be 3 epochs long, but they're definitely not as consistent as they would be if someone had normal regulation of REM. And they also have more, you can see here in the hypnogram, they also have more awakenings and they have more light sleep, right? So it's just that their sleep is, the staging of sleep is not as sticky as it is with when someone is a normal healthy control, if you will. Okay, so let's dive down into some of the new literature. Okay, so this here is a study in 2013, one of my favorite papers. This is by Tom Roth, and he really did a nice thorough review of, as per 2013, what we knew at the time about the macro architecture of the polysomnogram in patients with narcolepsy versus healthy controls. And you can see here at this time there were a few studies comparing the nocturnal PSG of patients with narcolepsy to controls. And essentially, I'm just going to kind of divert your eye to 2 pieces here. Number one is the top part of the bars, which is that light blue color, and that really represents slow wave sleep. So a combination of both N3 and N4. And then all the way down at the bottom is that darker blue color, and that is stage 1 sleep, so light sleep. And essentially what you can see here is that in the majority of studies that were conducted at that time or up until that time, patients with narcolepsy, regardless of the MSLT data, patients with narcolepsy generally show more light sleep, right? So they have more percent of sleep, which is on the y-axis, percent of sleep, of N1, and they have less deep sleep, okay? So what does that mean? That means that their sleep is essentially more choppy and it's less restorative. And they also show more frequent arousals and awakenings, okay? So these are people who have a hard time staying asleep and having good, healthy, deep sleep. Now, the more recent data that's come out since then, this is actually data from Andlauer et al., and this was after the paper from Tom. They're focusing on something very different. It's called the nocturnal short onset REM period, and this is actually where my research lives right now. And this is basically going back to the circadian rhythm. You're supposed to have REM at certain periods of time. We know that it's more common toward the nadir of the core body temperature, but it typically should happen between 90 and 20 minutes from sleep onset. And what we're finding is that patients with narcolepsy, both type 1 and type 2, have this very sort of strange early transition to REM. So what does that mean? That means that after they fall asleep, they go into REM within 15 minutes. Now, why is that abnormal? That's incredibly abnormal because the homeostatic pressure that has accumulated throughout the day pushes the brain to go into slow wave sleep first, essentially. So besides stage 1 and stage 2, they're supposed to, essentially we as mammals are supposed to have healthy sleep that looks like, slow wave sleep being dissipated first. So it's a real competing process, and when REM beats out slow wave sleep, something is wrong. And we know that because the sensitivity and the specificity for having this unique phenotype of a short onset REM essentially predicts narcolepsy, right? So 92% plus time, if someone has the short onset REM phenotype, they're going to have a diagnosis of narcolepsy. That's a lot. That's very high. That's much higher than the MSLT of having 2 short onset REMs and a mean sleep latency of 8 minutes or less. So if you, as a technologist, ever see this rare thing that happens, that's something that you should kind of think about, that even if that patient is there for a screening of sleep apnea or PLMs, it should really raise the red flag that something is amiss here, because the brain is supposed to go into other stages of sleep first before REM, not REM before slow wave sleep. Okay? Our data that we just actually published in 2015 proved that this not only happened in that classic type 1 phenotype, but it also happens in patients without cataplexy as well, so type 2 narcolepsy. And that's important because, narcolepsy, this thing does not just happen with that classic, what we think of as narcolepsy disorder. And this data is so strong that it actually prompted a diagnostic change in the International Classification of Sleep Disorders into the 3rd edition. What they said then is that, we actually appreciate this early onset nocturnal REM so much that we're going to allow that to count toward one of the MSLT short onset REMs. Okay, so if the person has 1 short onset REM on an MSLT, and they have this nocturnal short onset REM, guess what? They meet the criteria for narcolepsy now. No longer are they going to get dumped into the idiopathic hypersomnia bucket, and that's very important. So we actually just published this data. It's in Press in Sleep Medicine. This is our research group, and we're very excited, right? We're very excited to see what happened since the International Classification of Sleep Disorders 3rd edition came out. What is the prevalence of patients who have this unique phenotype, meaning this short onset REM? What is the rate of the MSLT use in those patients? We're hoping that it's like whopping because the ICD came out and said, hey, this is something that's important. Well, sadly, not many. So on average, about 11% of patients with the short onset REM get evaluated by an MSLT. And as you can see with those 2 little red arrows there toward the end of the graph, this is by year. So year is on the x-axis and percent is on the y. You can see that basically in 2013 and 14 and 15, only a handful of patients got evaluated by MSLT when they had a short onset REM. So like 2 out of 50 or 2 out of 40. So that was very concerning for us. And so we concluded essentially that even though the ICSD 3 made this change, that the MSLT is still being underutilized in patients with a short onset REM, despite the fact that many of these patients were incredibly sleepy. In fact, they were so sleepy that they were at like twice the rate of having a car accident or a near-miss car accident than patients with like severe sleep apnea, who we know are very sleepy. So what I am again doing is kind of planting the seed that if you see this as a technologist, especially as a practitioner, consider this phenotype to be narcolepsy until proven otherwise. Another area of research is the transition of sleep. Okay, so both we just talked about this. I don't want to beat a dead horse, but essentially people with narcolepsy have an inability or a harder time both staying awake but also staying asleep. And so what you can see here in this figure, this is a 2013 paper as well. It looks at essentially sleep-wake transitioning. Okay, so basically if I look at a hypnogram, it's how disjointed the hypnogram is. You can see here that essentially patients that have narcolepsy with cataplexy have on average, 5 to 6, let's say 6 transitions per hour compared to patients without cataplexy. And this is these are called box plots. So you can see here that the little red line that's in the middle of the square, those are medians. You can kind of think of them like averages, but it's just a different way of displaying the data. But patients, the upshot here is that patients with narcolepsy with cataplexy are at a higher rate of having more frequent transitions or that disjointed hypnogram compared to those even without cataplexy. And we see the same function with patients that have low hypocretin, which is what we think causes narcolepsy with cataplexy. We also see the same thing with rapid eye movement disjointment, if you will, right? So patients that have low hypocretin, which again is what we think causes narcolepsy with cataplexy, they have more frequent REM to other stages, essentially, transitions. So their REM is disjointed as well, okay? All of that makes sense. But very important because you can get that data from the PSG, okay? So if you're conducting the PSG or you're scoring the PSG and you see this, it should kind of raise the red flag. Again, this is data from 2015. This is very recent data, and this is again looking at that sort of disjointed hypnogram as well as information about percent of N1, which is light sleep, right? So again, these are box plots, but essentially the upshot here is that you can see patients with NT1 compared to other hypersomnia-like conditions, so idiopathic hypersomnia and narcolepsy without cataplexy. They essentially just have more disjointed sleep and more essentially stage 1, so light sleep. The newest data that's out is really cool. It's about sleep stage sequencing. So it's not necessarily about how frequently we're transitioning between stages, but how we transition, what stages we're transitioning to. We know that essentially transitioning from wakefulness or N1, so light sleep, into REM is fairly abnormal based on what the brain is supposed to do when it goes into REM the first time. It's normal to go from essentially N2 or N3 into REM. This is here a figure that shows wakefulness or N1 to REM transition, which is not normal. You can see how frequently that happens. So when a person falls asleep and goes into REM through either wakefulness or N1, that should again trigger your suspicion that something is amiss as far as it being a central hypersomnia condition. So 60% of patients with narcolepsy with cataplexy go into REM from wakefulness or N1, which you can essentially see there on that first portion of the graph happens almost none of the time for patients, healthy controls, if you will. The last thing I want to talk about is the spectral characteristics. So we're finding that, again, it's not just, the number of transitions or how we transition, but it's actually this homeostatic drive of sleep that's very different for patients with narcolepsy than it is with controls. And what we're finding is that patients with narcolepsy, you can see this is a curve. Time after sleep onset is on the x-axis. On the y-axis is the percent of slow wave activity. So you would expect slow wave activity to be the highest in the beginning of the night and lowest toward the end of the night, where it should be mostly REM. We're actually finding that patients with narcolepsy have a very overly efficient homeostatic drive. So you can see that the open triangles here, if you follow the dotted line for the open triangles across the x-axis, you can see that the function or the shape of that line is steeper for patients with narcolepsy. And essentially what that means is that they have so much, N3 in the beginning of the night that they actually cannot stay asleep for the rest of the night. They end up fragmenting their sleep or having that disjointed transition, if you will, lots of transitions, because their slow wave sleep is gone, essentially, by the time they hit the second cycle. So just to summarize, the MSLT that we have currently is imperfect. It's the best that we have besides, doing a spinal tap for hypocretin, but we don't really do that very often because no one's going to, raise their hand for that. And there is need for better tests with more sensitivity and specificity. The understanding of narcolepsy is definitely rapidly unfolding with regards to the importance of looking at the nocturnal PSG in terms of both the structure of sleep, the timing and sequencing of REM, and as well as the spectral characteristics, so that homeostatic and circadian pattern in patients with REM. Now, the important thing is that many of those characteristics that I just talked about aren't standard reporting items. So in an interpretation template, they don't populate. So you as a technologist, you play a very important role in this. And so I encourage you to bring this up to your medical director if you do see it. And that is the end for me. Thank you.
Thank you so much, Dr. Cairns, for that informative presentation. I am now pleased to introduce Timoteo Oyegbile, MD, PhD. Dr. Oyegbile joined MedStar Georgetown in 2013 in order to pursue research as part of her clinical practice. Her specialty combines her interest in the brain and its function with her desire to work with kids. In addition to her medical training, she holds a PhD in neuroscience. Her special interests include epilepsy and sleep disorders. Welcome. We're ready to learn from your expertise.
So hello, thank you. Can you? I'm assuming you can hear me. Let me know if you can't. So I know we're a little bit behind, so I'm going to go as quickly as I can. And my goal here is to kind of discuss more about the physician delay in diagnosis and what exactly physicians are doing to delay the diagnosis and how we can improve that over time. So Julie and Alyssa, Dr. Carnes, have already gone through some great information about the history or the information about narcolepsy, and so I won't spend too much time with the background, and I'll kind of go and move forward as quickly as possible. So narcolepsy, as we've heard by the first two speakers, is a chronic neurologic disorder. It involves dysregulation of the sleep-wake cycle, and the hallmarks are excessive daytime sleepiness, cataplexy, hallucinations, sleep paralysis, and disordered nocturnal sleep. And it's often associated with the loss of orexin or hypocretin-producing neurons. And this little cartoon that I have down here is actually not to be facetious, but similar to what Dr. Carnes had mentioned, motor vehicle accidents with people who have narcolepsy it's significantly higher compared to many different other neurologic disorders. So something we have to keep in mind is that the quality of life of patients with narcolepsy is significantly reduced. Now, this study looked at the quality of life of narcolepsy associated with other neurologic disorders, and we found that narcolepsy is pretty low down there with Parkinson's in terms of quality of life. So if you take a look at this graph, you'll see that the red line is associated with the general population, and then we have different lines for epilepsy, narcolepsy, and Parkinson's, and the green line is narcolepsy, and we can see that they do pretty poorly in terms of the quality of life, ranging in the 30 to 50 range, as opposed to general population, which is more in the 80s to 90 range. So let's talk about the prevalence of narcolepsy. We find that it's actually pretty rare. So it's 1 in 2,000 patients, and there really is no gender differences, and this is specifically in the United States. The demographics are similar to what Julie had mentioned earlier, is that it tends to occur in younger ages, the teens to 20s. You're more likely to present with sleepiness or symptoms of sleepiness, which could be quite different from sleepiness itself. And quite a few do present with cataplexy, but they're significantly less compared to those who just present with sleepiness. When patients present with cataplexy, their chances of getting diagnosed quicker is much higher just because cataplexy is pathognomonic for narcolepsy. And so pretty much most physicians, the knee-jerk reaction, they're like, okay, fine, this sounds like narcolepsy, and probably are more likely to test for it and treat. So let's talk about the diagnosis delay. And this we've kind of heard from the last two speakers, but I'll quickly summarize. Usually the onset of symptoms is about around 10 years of age or a little bit less, and the symptoms peak, so the worst symptoms are usually in the teenage years to the early 20s, and the average delay is about 10 to 15 years. So it's very similar to what Julie described. Turns out the range is actually much wider than that, anywhere from 1 year to all the way to 61 years, so basically most of your life never being diagnosed with narcolepsy. And this is kind of scary. Now this delay is actually consistent across different countries, different continents. So we find the same thing in Austria, in Canada, in France, Germany, United States, UK, Saudi, wherever we find that we actually see similar delay. And this can likely be associated with prevalence, among other things, which I'll talk about in more detail. So let's talk about predictors of delay, which have been kind of discussed a little bit from the two former speakers. The pediatric onset is a big one. It's often, we often see this onset at such a young age that a lot of kids are unable, at this age, they're unable to articulate that something has suddenly changed and something is actually different and wrong with their wakefulness. They just suddenly start getting sleepy, and then parents look at this and think about perhaps they're just, uninterested or unmotivated, and so we end up finding that it's the kids who have this onset in very young ages that tend to have very, very delayed diagnosis. Other presentation symptoms like depression and fatigue and cognitive difficulties, these are not the typical symptoms, quote unquote, of narcolepsy. And so if you come in complaining of depression, et cetera, you may end up getting referred to a different physician and not necessarily a sleep specialist. The number of presented symptoms, obviously, if you come in with just depression, people will think, physicians will think probably send you to psychiatry or psychology, but if you mention excessive daytime sleepiness, hallucinations, and cataplexy, you're less likely to end up at the psychologist referral desk. And of course, being female and a higher BMI can lead to a delay in diagnosis as well. Of course, when you're thinking about higher BMI, even if you see a sleep specialist, they're more likely to think about OSA than they are to think about narcolepsy, even though we know that these two symptoms are related. Now, let's talk about the physician's reasons for delay in diagnosis. Just quickly, briefly, the onset and presentation is one huge one. Prevalence, symptoms, diagnostic testing, access, and then physician exposure, which I'll go into in detail. Let's first talk about the prevalence. So as I mentioned earlier, it's quite rare. So 0.05% of the population in the U.S. and 0.06% worldwide. So usually, most physicians are not looking for the zebras, they're looking more for the horses. And so this is kind of another thing where if you come in with even sleepiness, they're less likely to be thinking first knee-jerk reaction is narcolepsy. They likely are thinking of other reasons. However, the good news is that if you have one of the disorders that is closely associated with narcolepsy, such as myotonic dystrophy and Niemann-Pick type C and Prader-Willi syndrome, these are patients that in general, once they're in the system, they end up getting referred to a sleep specialist right away. And we actually will start anticipating these symptoms of narcolepsy in advance. Most parents or patients will be informed in advance so that they can actually be looking out for the symptoms of sleepiness or cataplexy, et cetera, even before it starts. that's the good news there. Now let's talk about the onset. Kind of similar to what the other speakers have mentioned earlier. The onset can be quite gradual, but more importantly, the onset can be something totally unrelated to narcolepsy. For example, studies have shown that the precipitating event that brings on narcolepsy can be an infection, so like strep, H1N1. And so if you have a kid who had strep and then soon after they start developing symptoms of sleepiness, one might think, maybe the infection is not completely worn off. Perhaps we need to treat it a little bit longer. They would be thinking of things like perhaps we should be testing for mono, which is associated with chronic tiredness. And so these are patients who would end up in the infectious disease office for much longer than they need to because actually their symptoms are actually narcoleptic and not infectious. Also, some of the symptoms actually imitate other disorders. So sleep paralysis, for example, in the teenage years, if I were to see a patient with only sleep paralysis, I would be saying, it's actually normal in teenage years and in the early 20s, and so I would not knee-jerk reaction think of narcolepsy, even though as a sleep specialist it would be on my radar and it would be on my list, but I usually don't think of it as the very first thing because sleep paralysis is actually quite common. Hallucinations. If a patient comes in and says, I have hallucinations, they're always right as I fall asleep or right as I wake up in the morning, you're less likely to think, this should be narcolepsy. I think you'd be thinking more of psychiatric disorders. Also, a lot of patients who come in with sleepiness, especially pediatric patients, usually it's the parents or teachers complaining that the kid is not focused in class, is falling asleep, is not thinking clearly. And so if we have these symptoms or symptoms like poor attention, poor motivation, poor academic or work performance, we're thinking more of ADHD than thinking of narcolepsy, just because ADHD is more common. And then cataplexy has often been misdiagnosed as seizure because seizure, of course, is more common than cataplexy. And so you can imagine that all these symptoms, especially if they are given to the provider singularly, so not all together, the provider might be thinking of other disorders and not just narcolepsy. And keep in mind that all of these other symptoms and disorders are actually way more common than narcolepsy. So let's talk about sleepiness. So first of all, as I mentioned, a lot of patients do not present with sleepiness, but instead present with symptoms of sleepiness like poor motivation and inattention, etc. But even if you do come in with sleepiness, if you look at the studies that look at people who come in with sleepiness, about 95 to 98% of them have anything but narcolepsy. So a lot of them who have sleepiness end up having just behaviorally induced insufficient sleep, so they're just not sleepy enough. They have poor sleep hygiene, or they're stressed and so not sleeping as well. These can be people who just are carrying their iPads and iPhones till late, or watching TV till late, and so end up having more issues with their sleep. And so that's what most sleep specialists or primary care physicians are thinking about first before they think about narcolepsy. And of course, idiopathic hypersomnia, which was mentioned before, can be something that we think about on the list as well, and mood disorders, which I mentioned earlier. Also, other sleep disorders such as OSA and insomnia do sometimes present with sleepiness, and so we're more likely to test for these disorders before narcolepsy. Now let's talk about the diagnostic testing, which the former speakers have also mentioned as well. PSG and MSLT would be the first thing we think about if we want to assess for narcolepsy. So say, for example, this patient who has narcolepsy has made their way to a sleep specialist. We would order a PSG and MSLT. Just keep in mind that this test is actually very time consuming and it's also quite expensive. So it takes up basically a full day, 24 hours, to get this test done, which can be a lot for the average patient, especially if it's during the week. And then the expense is quite high. Some hospitals, charge as high as $10,000 for the full test. And imagine paying at least, even if it's 10 or 20% of that, which the patient has to cover. That can be a lot and can be a bit of a deterrent. Also, there are several insurance restrictions. I, as a physician, may order the test. However, if your insurance says you can't get the test, then we end up having more reasons for delay. Also, the current regulations by AASM and by most insurance companies require that the PSG has to be fairly normal before you can do an MSLT. And so you can imagine if you have a patient who has coexisting OSA and narcolepsy, because maybe perhaps they have a higher BMI, then we would have to stop at the PSG and we cannot do the MSLT. So there are, once again, lots of issues with the means of diagnosis. And of course, as has been mentioned before, MSLTs can have lots of false negatives. So one thing that has been recommended is having Epworth sleepiness scales or other sleepiness scales performed by primary care physicians or even sleep specialists. Most sleep specialists do perform a lot of sleepiness scales. The issue is that these scales come up positive for many different disorders, just like OSA and even insomnia. So you can't always use that as the clincher for narcolepsy. So tests that are a little bit more definitive for narcolepsy will include genetic testing, which is not 100%, but a good amount of patients will come up positive on the genetic testing. But genetic testing, once again, can be quite expensive. A lot of insurance companies do not cover it. So that right there is one of the reasons for delay. Furthermore, another test that's actually quite good is the lumbar puncture, which looks for hypocretin levels. Now, as you can see in this slide right here, individuals with the typical cataplexy are more likely to have lower hypocretin levels if you look at the red column. However, there are lots of patients with narcolepsy in general that will have normal hypocretin levels, and so this is not, even though it's a great test, it's not completely inclusive, and so lots of people will be will not qualify to have narcolepsy if we just use this testing. So there definitely is a lot of issues with diagnosis, and as Dr. Carnes has mentioned, there's lots of research being done to improve this. Access is another big thing as well. So sleep labs tend to be quite full. In general, you'll get your order for a PSG and an MSLT, and then you've got to wait another like 6 months to get in for the sleep lab because they're all full. And also sleep specialists are hard to find, especially pediatric sleep specialists, which is when the that's usually the time of onset. You may wait. You may end up being referred to several other physicians before you finally see a sleep specialist, and by then there has been significant delay. Also, the approach to sleep disorders is quite different between pulmonology sleep specialist and narcolepsy sleep specialist. Now, Julie had mentioned earlier that she had seen a sleep specialist and her throat had been looked at, etc. And then when the sleep study was normal, she was sent on her way. This is, of course, unfortunate, but this happens quite frequently just because of the fact that pulmonologists, for example, are focused more on lung disorders or disorders of, obstruction in the throat, whereas neurologists kind of approach it a little bit differently. And so this has been an issue in terms of like the sleep specialists that are out there. Each one has their own area of specialty. And so how can we deal with this issue so that people aren't getting lost in the system just because their PSGs were normal? Lastly, this is something that Julie had mentioned earlier as well, was that in general, if you're not going to sleep medicine, most physicians have very, very limited sleep training. And so on average, if you look at the studies, it would be about 2 hours of sleep training that's done throughout medical school as well as residency. And so this is definitely not enough to even know the basics of what is abnormal sleep, talk less of being more specialized, talking about narcolepsy. And so our physicians in general are very, very much unprepared to be excellent sleep physicians, to be excellent at catching sleep disorders long term as they go into their careers. So this is all unfortunate news, but let's talk about what we are doing to try and hasten the diagnosis. So one big thing is the push through AASM to now start pushing comprehensive sleep centers. So as I mentioned, each one of the different sleep specialists have a different approach towards sleep disorders. And so having a comprehensive sleep center where you have the neurologist, the pulmonologist, the ENT doctor, the psychiatrist, the psychologist working all together, this is an excellent way to actually make sure that individuals do not fall through the cracks. And so, for example, a sleep specialist who finds a normal PSG will likely talk to the other sleep specialists in the same sleep center to say, hey, what should be the next step? What else should we be looking for? Let me refer the patient to you so you can also assess this. And this is studies are now showing that using comprehensive sleep centers that have multiple sleep specialists are more likely to come up with the right diagnoses than having single sleep specialists in centers. Now, National Sleep Foundation, this is one of their pushes as well to actually improve sleep awareness in general. Now, I currently am the NSF Sleep Health Policy Fellow. And what we're doing is that we're actually going out to Congress and to Senate weekly discussing the need to improve policies that can actually push out sleep awareness to not only the public but also to physicians. And so our goal is to actually improve awareness in the public and also to improve sleep education in medical school as well as in residency. And so so far we've been able to make some changes, but we continue to move this forward because this is kind of an ongoing thing. If we can at least get people out there to see on TV or in different areas or even in their physicians' offices, see flyers or information on sleep, they'll become more aware of it and be more likely to talk to their physicians about, their primary care physicians about their sleep problems, and then we can begin the conversation from there and actually move them towards seeing a sleep specialist. And even something as simple as just having an Epworth Sleepiness Scale provided by the primary care physicians can open up a discussion about sleep and actually move things forward and kind of be able to get patients into sleep centers sooner than later. Now, let me tell you the good news, and this is something that Julie had already referred to or discussed a little bit in her talk. The good news is that this is the trend of narcolepsy. What we find is that the diagnosis delay has actually improved significantly over the years. And so if you think about the 1920s, 1930s, people would go almost their whole lives without any improvement in their sleep, any diagnosis in their sleep disorder. And so they would go their whole lives being sleepy and probably having very poor quality of life, but never knowing what their diagnosis was. However, now, and this study is actually pretty old, this is 1998, the more recent study has shown that it's actually improved since then, but this really beautiful graphic shows that we are actually beginning to diagnose patients a lot sooner, within about 3 months to a year, and more importantly, more people are actually beginning to come into the sleep specialist, which is very important. And so this is kind of the best news, but we know that the work continues, and we still have to keep pushing out information about sleep and sleep disorders, and so that is our goal, to continue this. All right, I know my time is up. I know we have limited time, so this is time for questions.
Excellent. Thank you so much, Dr. Oyegbile, for sharing a wealth of practical information. And yes, let us go ahead right now and dive into some of the questions that we have received. And thank you to all of you. I see many of you are still sticking around, so we really appreciate that. Let me do our first question. If you have a question, use the Q&A box on the left-hand side of your screen. Question 1, if a patient is falling asleep or is asleep before the actual in and out of a sleep study, which does happen no matter how much you encourage them to stay awake, they will possibly have short onset REM by PSG, but it would be incorrect. How do you handle that possibility? Dr. Cairns, I believe this came in during your presentation. Would you like to take a stab at it first?
Yeah, sure. No, this is a great question because it's definitely something that is oftentimes unavoidable, especially if they have, true narcolepsy. I mean, it's very difficult to get a patient to stay awake when they are so overwhelmingly sleepy. Even though that burst of sleep may only be very transient, it still is very difficult to avoid. So yeah, definitely try to avoid it at all costs, right, which I know you all do. But if it does happen, just kind of keep that in mind when you're looking at the data. But also it's not a deal breaker, because patients that really do have true narcolepsy, they oftentimes go right into REM after they fall asleep at any time, right? So like I said, the transition from wakefulness or N1 into REM is much higher for patients that have narcolepsy versus those that don't. And so theoretically, even if they already had a mini REM episode previously, you would expect them to have another one, okay? So yes, it's not great to have them fall asleep earlier, but don't beat yourself up too much when it does happen, because theoretically it should happen again.
Thanks. Would anybody else like to jump in on this question before we do the next one? Okay, next question is, are there any blood tests that you recommend prior to having a PSG MSLT to help diagnose narcolepsy? Dr. Oriegbile, do you have an opinion on that?
Absolutely. So this is a great question. So that's an excellent question. There are several different reasons for sleepiness, as I had mentioned earlier. One that I didn't mention is like thyroid disease. So there are many, many different blood tests that can be done to look for or to rule out other reasons for sleepiness while you're waiting for the PSG. And of course, the genetic testing is also key, because the genetic testing, which is generally blood or saliva, can also help as well, because if that comes up positive, then you're more likely to convince a sleep specialist to, make sure that they're seen quicker or get them in for the PSG MSLT a little bit quicker, and that will definitely help with the diagnosis delay to improve that.
Excellent. Anybody else want to comment on blood tests? Okay, we have another question. How common is a combination of narcolepsy and sleep disordered breathing? Dr. Cairns, would you know?
Yeah, approximately. So it's a great question. It's more common in patients with narcolepsy, and it may be mediated by leptin, which is a hormone that's secreted by fat cells. Patients with narcolepsy are oftentimes more likely to have precocious puberty, meaning they develop sooner as far as sexual maturation, and also oftentimes they have more body fat content, and potentially through this leptin pathway. And so we do find that simply because they're more likely to be overweight, they're more likely to have sleep apnea. So the general estimate right now is somewhere in the order of magnitude of 25% of patients with narcolepsy have sleep-disordered breathing. That's pretty conservative, though, because I think the data is actually like an AHI of 10 or greater, versus those in the general population, which is a conservative estimate of anywhere between 4 and 10% right now.
Excellent. Thank you for that information. Dr. Oriegbile, do you recommend urine screening prior to MSLT for drug use?
So I definitely would recommend it. I think it's a great screener, just to make sure that you're not missing other reasons for being sleepy during an MSLT or not being sleepy during an MSLT. And so that's something that's definitely recommended. Of course, most sleep centers these days are not set up to do urine screens, and so it's something that AASM has not been pushing, but it's always very helpful, because then you can kind of be able to answer the results of the MSLT a little bit nicer when you're actually reading the study. You're kind of like, wonder what's going on. You've got the urine screen right there to tell you if the patient is on a certain medication that could be explaining why they're either more awake or more asleep than you would expect.
Excellent. Would anybody else like to answer related to urine screening? Okay. We have another question that anyone can jump in on if you have an answer to this. Somebody is wondering if there is any facility or lab doing hypocretin testing, and if so, where Does anybody know the answer to this or is familiar with one? Okay.
Yeah.
So
I
go ahead.
sorry, this is Alyssa. Yeah, it's tough, right? Because it's definitely not something that is a standard metric that insurance companies are covering, and I don't think that there's any publicly available test out there for hypocretin. Like you can go and get it anywhere. But I do know that Emmanuel Mignot at Stanford is a person who does hypocretin. I don't know if he offers that as a service publicly to other sleep practitioners, but he is someone who often does it as per standard with all of his patients because he is one of the, if not the leading world expert in patients with narcolepsy or narcolepsy with cataplexy. So you may want to reach out to him or at least look at his offerings on his website. So that's going to be that's Stanford University, and his last name is Mignot, Mignot.
Excellent. Well, thank you. And again, I appreciate the majority of you who stuck around through our questions, despite us going a little bit over time today. And I would also like to thank the presenters for answering so many questions and for their excellent presentations, of course. And thank you to all of our audience members. Today's webinar is being recorded, so you may re-watch it for free anytime in the next 3 months using the same link you used to log on today. Feel free to share the link with colleagues who may have missed today's live event. Email me at sroy@allied360.com with comments, questions, and future webinar suggestions, and visit us at sleepreviewmag.com. There's a link on the right-hand side if you'd like to subscribe for free. And thank you for participating in this Sleep Review webinar.